Well, welcome to the Center for Global Development, and thanks for coming to this event that we, of course, couldn't resist using the pun on the UK National Institute for Health and Clinical Excellence. They have the wonderful acronym NICE. So we naturally had to use that in the title. I'm sure you're sickened by it already, but hey. So rationing healthcare, which is choosing what interventions will be publicly financed and for whom, is really a global problem. Resources are limited everywhere, and choices have to be made. But it's also a very old problem, very politically difficult, and it's one that not all the wealthy countries have figured out, and not all the developing countries have figured it out either. So it's really a space where we can all learn from each other. And I'd say that, unfortunately, most priority-setting processes in the world remain ad hoc, resulting in things like implicit rationing of health care, the first come, first serve, whoever can pay gets the service. If you live far away, you're not in luck. We'll give lower quality to people for certain kinds of services. We'll treat the sickest first. These are all decisions that have an impact on the cost effectiveness of our health systems, but that we could actually do differently if we were engaged in explicit rationing. In some cases, we see explicit rationing. There's the case of the Arizona's Medicaid program last year, where faced with a budget limitation, they looked at the high-cost items in their budget, and they cut transplants from one day to the next, with little concern for social preferences or what might be cost-effective or other kinds of criteria in that decision-making process. And from a developing country perspective, even when an intervention is affordable, we still see limited country funding for or adoption of or use of very highly effective, cost-effective interventions, while we see public spending on health on less cost-effective or even ineffective interventions. And some examples of that could be, for example, that 44% of children between the ages of 1 to 2 are fully vaccinated in India, but open heart surgery is fully subsidized in national public hospitals. In Colombia, 58% of children between 1 to 2 years old are fully vaccinated, but bariatric surgery is fully subsidized by the public sector. In Egypt, 20% of children are stunted. We know how certain interventions that we could do that would improve that situation at fairly reasonable costs, but 20% of public spending on health goes to send a growing number of patients overseas for treatment. So these kinds of facts that we're faced with pose very difficult problems and argue for trying to find solutions to carry out more explicit decision-making processes that would be defensible both on technical grounds, cost-effectiveness, financial protection, and equity grounds, but also in legal and ethical terms. So today our focus is on processes and institutions that can help with this difficult political economy of priority setting. What institutional features can help to bring evidence and preferences to decision-making about public spending on health? We're not talking about the drug registration process. That's something that focuses on safety and efficacy. We're not even talking about methods and metrics associated with cost-effectiveness analyses, although that's certainly part of the process that we're talking about. And we're not talking about solutions that are particular to any health system model. I think there's been a perception in the United States that this kind of explicit rationing can only happen in a national health system, right, where you have a budget limitation. But the fact is, anytime we deploy public spending for health care, we have to make these choices, be it an insurance system, be it a national health system. Why is CGD interested, or why am I personally interested in this issue as a fellow here at CGD? Because aid institutions and instruments can create incentives and disincentives for greater allocative efficiency in recipient countries' own health spending. We have the case of Gavi, which is the Global Alliance for Vaccines and Immunization, that basically leverages public spending in favor of vaccination. Well, we can all agree on that because vaccination is a very cost-effective use of public spending. But things get more controversial when we get into the space of PEPFAR and the Global Fund, when we're talking about doing treatment for HIV/AIDS and other issues. In some cases, that's considered more or less cost-effective than other uses of funding. So that's something to consider, how the global institutions are affecting the way recipient country institutions are allocating their resources. The other issue is that health is a growing fiscal, legal, and development effectiveness challenge, particularly in the middle-income countries. In Latin America, where I've worked for many years, and the right to health or the right to life is enshrined in many constitutions, patients and the industry are taking government to court for specific treatments. And that happens in insurance systems like Colombia, and it happens in national health systems like Brazil's. And this aggravates the efficiency problem to the extent that 20% of Colombia's income for health insurance or contributions to health insurance are going to court settlements and to fund treatments that are actually not endorsed as cost-effective in the wealthiest countries of the world. And Colombia is not alone. So today we'll talk about one institution that has developed an explicit process for priority setting, NICE, and the work that they're doing in support of developing country priority setting processes. And I'd like to say that NICE is not the only institution of its kind. Many times people point at NICE because it's the most prominent and because it's been very influential. But the U.S. Veterans Administration also has a process of explicit priority setting. The Australians have one. Most of the European countries have similar kinds of institutions. They all have different features. They have pros and cons, and that's a little bit what we'd like to talk about here today. And our discussants today is Dr. Sherry Fink, and unfortunately Dr. Norman Ornstein was not able to join us due to a family emergency. So with that, I'll turn it over to Sir Andrew Dillon, who's the CEO of NICE, to tell us a little bit about how NICE works and how they contribute to this debate. Thank you.
Thank you very much, Amanda, and good morning, ladies and gentlemen. First of all, a big thank you to the Centre for giving us the opportunity of coming along today. It's great to be able to talk a bit about what we've done in the UK, but also to extend that, and this is what my colleague Kalipso Chalkidou is going to do, to talk about how other parts of the world have taken a look at what we've done and in some different ways try to apply it to support the process of using evidence to inform their policy and practice decisions in the way that they want to. Because probably the most important message to get across about our international activity is you can't take NICE, or indeed any of the other organisations that Amanda just mentioned that have grown up here in the US and elsewhere in the world, and transplant it to another jurisdiction. It simply doesn't work. But there are aspects of what all of these organisations have done which may be helpful, probably are helpful to all health systems, including the one in the UK, actually, because NICE learned a lot from many of these institutions as it set itself up 11 or 12 years ago to help improve the way resources are used to deliver good quality health outcomes. So all I'm going to do is, I've got about 5 or 6 slides that just pick on a few issues of what's happening in the UK and the way NICE works as a kind of primer for any questions you want to ask and as a bit of context for what Kalipso is going to talk about in a few minutes. Just want to say this first of all. I mean, those of you who in any way follow the story of NICE as it's sometimes played out in the US, and certainly as it was in the UK about 3 months or so ago, as a result of statements that were made by health ministers in the United Kingdom, some newspapers misinterpreted that as the end of NICE. It was all over for NICE. And we were going to go for some fundamentally different system. Well, reports of our death, I've always wanted to use this quote, reports of our death have been greatly exaggerated. We're certainly still there, still thriving, still very much, as I'll explain at the moment, part of the new government in the UK's plans for the National Health Service, still a big contribution to make, doing pretty much what it is that we've been doing for the last 10 years or so. And just talking about the last 10 years or so, here's in one slide a short history of NICE, just to explain the things that we do. The coloured bars don't matter that much. They just show volumes of outputs from these different programmes. But you read the slide from left to right, obviously. And here in 2000, although we were set up in 1999, we've got the Technology Appraisal Programme. This is the thing for which NICE is best known, probably internationally, probably in the United Kingdom as well. This is the programme that, amongst other things, looks at new drugs licensed in the United Kingdom and provides advice to the National Health Service on their optimal use. This is the programme that sometimes generates very controversial recommendations, most frequently, certainly over the last few years, relating to last-line treatments for cancer, where by making that judgment about whether or not the incremental benefit of a new treatment is worth what the health system is being asked to pay for it, there have been circumstances in which we've either recommended against use or we've recommended use only in certain circumstances. Though I should say, just interesting fact about NICE, that if you look at the totality of the advice that we've given on new treatments over the decade or so that we've been going, our recommendations about 83% positive, slightly less for cancer treatments if you just isolate those from the total group of technologies that we've looked at. But in most cases, we find value in new treatments that are being made available to the NHS. And pushing the health service to adopt new treatments more quickly than historically has been the case was one of the main reasons for NICE being established. And I believe, although there are clearly some very controversial exceptions, by and large, we've delivered on that particular brief. Anyway, reading left to right, you can see here the programs that have been added through the years. A clinical guidelines program, this is where we look at care pathways in whole diseases and conditions, so sequencing recommendations on diagnosis and treatment, as opposed to the single intervention recommendations that we make in the technology appraisal program. We provide a kind of quasi-regulatory advisory program on the use of new interventional procedures. So here we're looking at the safety and efficacy of the procedures rather than their relative effectiveness. In 2005, we took over responsibility for advising on effective practice in public health in the United Kingdom. And more recently, you can see right over on the right-hand side of the chart, an acceleration of new programs being added into the portfolio of work that NICE does. And just maybe picking up on a couple of them, that QOF there, that stands for the Quality and Outcomes Framework. That's a description given to the about 20% of the income of family physicians in the United Kingdom, which they earn by delivering against specific indicators. So it's an incentive payment mechanism. And the idea is that, periodically refreshed, these incentives have the ability to improve the quality and the consistency of care provided by family physicians. There's a similar incentive mechanism in place in secondary care for certain aspects of clinical practice, and I'll come back to that in a moment too. And then the other thing, just to feature on this, is the Quality Standards Programme. NICE's quality standards are essentially synthesised from the clinical guidelines that we've published. Clinical guidelines, as you know, though they vary in their presentation, from telephone directory-sized publications through to some slickly presented, beautifully crafted descriptions of the sentinel aspects of care, can often be quite daunting and difficult to access. So what we've tried to do with the quality standards is just to extract the sentinel markers of good practice. It's certainly not a textbook, but if you're doing these things and you're doing these things well, then by and large, the rest of what you need to have in place to produce good quality care in that particular aspect of clinical practice is likely to be in place as well. And the plan is to produce a library of around 150 to 200 quality standards, covering the bulk of the practice delivered in primary and secondary care in the UK. And they're going to be very important, as I'll come on to in a moment, in the new architecture that's being put in place in the NHS. And this new architecture, introduced by a government that was elected in the summer of 2010, and these days, new governments' changes in the United Kingdom don't seem to be quite as dramatic as they were a few decades ago. There's been a sort of subtle shift from centre-left to centre-right, with a coalition government now in place, a coalition of the Conservative Party and the Liberal Democrat Party. But all new governments coming in, quite appropriately, look at the major components of public enterprise that they're responsible for directly in the United Kingdom. The health service is a very significant element of the government's responsibility. One of, certainly for most citizens, almost the most public aspect of what it is that government provides. So it's inevitable that new governments coming in want to take a look at how the system can be changed and improved, and this government is doing that too. And here's essentially what they're what they're putting in place. Their sense was that the predecessors, the Labour administration, had centralised too much control of the public health system. That although responsible, clearly, as the government is, for more than £100 billion worth of the nation's wealth, you can't control a health system from central government. And so what they want to do is to push the responsibility for designing and delivering health services away from the Department of Health in the centre out to the delivery end of the system, to those people who are actually have the responsibility for delivering care. Now, in its way, this is not dissimilar to the sort of ambitions that most governments have when they come into office. There's always this sense that we need to make sure that as government all we're doing is crafting the policy, making the big priority decisions, that it's not the business of politicians or bureaucrats in central government to try and micromanage the way the health service is actually delivered on the ground. So this is this government's interpretation of that typical reaction when new governments come into office. They want to shift power out, and there's a number of aspects of how they're doing that, the most important of which is the second bullet point. I'm not going to bore you with a history of the evolution of systems of administration in the health service, but right now, though it's not going to last very much longer, this is how it works. Parliament decides how much the health service, how much of the nation's wealth is going to be spent on health. It's about £100 billion. It then more or less divides, apart from certain central reserves, it divides that up and it gives it to what are called primary care trusts. These are local organisations covering populations of maybe 600,000 to 1 million or so people. And there's 100 plus primary care trusts covering the geography of England. Those primary care trusts are responsible for two things. They commission family physicians to provide primary care, and they commission hospitals to provide secondary care. That's what they've done. That's going to change in 2013. That entire system, that backbone of primary care trusts, is going to be dissolved on the 1st of April 2013. And it's going to be replaced by groups of family physicians who are going to be given the majority of the budget for the NHS. Now, this is a huge change in the system. It's a big change, obviously, for the people who work for primary care trusts at a very personal level. But it's an enormous change for family physicians, because although they've long felt that that their ability to influence the design of the health service locally has been underutilised. Being given the totality of the responsibility both to design the health system locally and to account for and to control the resources that are given to them locally is an enormous step. And though there are some family physicians who are very enthusiastic about that, there are many who are concerned about their ability and their capacity to do so. But notwithstanding the very considerable risks, it seems to me the prize associated with that change is that you put people, family physicians, who have an intimate understanding of the needs of their local populations and a good understanding of the nature of and the way in which secondary care needs to change because of the interaction they have with their hospital colleagues routinely. If they do that well, if they get it right, there's a real opportunity for making significant improvements in the quality of care provided by the hospital infrastructure in the UK. So a big opportunity, but potentially quite a big risk too. The government wants to move away from simple targets in terms of assessing the performance of the NHS. 10 years ago, the big problem in the health service was waiting lists and waiting times. You quite often wait 2-3 years for elective procedures, sometimes longer. Sometimes you waited too long and you never had that chance to have your heart valve fixed or whatever it was. That's all gone, largely as a result of the last government's drive to improve access. Now you can pretty much pick when you want to have elective procedures in the UK. Waiting times are really a thing of the past. So targets have their value at certain points in the evolution of health systems. What this government wants to do is to describe a set of outcomes for the main services provided by the NHS. And it wants to hold the performance of the health systems at a local level to account based on the progress they make towards achieving those outcomes locally. So there's going to be a national outcomes framework. And part of our contribution to that are these quality standards that I mentioned a moment ago. Because when we go into work, generally speaking, we don't go in and do an outcome. We do process, by and large, and we do the process things because we believe that either because we've just convinced ourselves on some basis, or ideally because we've used the evidence to inform those decisions, that those actions will contribute to good outcomes in whatever it is that we do. So what we're trying to do is to supply those family physicians and their hospital colleagues with as simple as possible expression of the key things that need to be in place in the services that they provide in order for them to reassure themselves and their patients that they're moving in the direction of delivering on those outcomes. So that library of 150 to 200 quality standards is going to be quite critical, I think, in the ability of the health service to deliver on the new government's ambitions. But here's a big issue right at the bottom here. It's all great. It's moving in the right direction, some risks associated with it, but there's no extra money. There's a tiny little 0.1% real terms growth going into the health service, but in practice that's not enough to feed the beast. Because it's true in the US as it is in every health system, that the cost of delivering healthcare outpaces any other kind of inflation. You've got to continue to feed it one way or another. Either you put extra money in, you just expand the budget, or you dive into the budget that you've got and you take out the inefficiencies in the system and you use that to create the headroom to do the new things that you want to do. Well, that's what the NHS has got to do. I'm not quite sure of the exchange rate when I did this slide. It's about 15 to 20 billion pounds that the system is trying to take out. Well, 20 billion is a fifth of the total budget. It's an extraordinary challenge. The health service has never done that. I've worked in the health service all my career, mostly running hospitals, so I've got some experience of trying to redesign budgets, redesign services to make efficiency savings, and none of my experience would inform the sort of work that has to go on to do this to achieve this kind of saving. It's huge. But unless the NHS does it, it puts two things at risk, I think. One is its ability to continue to meet the expectations and the needs of people who use the publicly funded health system in the UK, and that's most of us, by the way. There's, I don't know, about 12 to 15% of UK citizens have private insurance, usually for elective procedures, but pretty much everybody relies on primary care provided by the NHS, and most of us use secondary care health services. And we all have growing expectations. We know there's no money, but we still have growing expectations. So our ability, the health service's ability to do that's going to be at risk. The other thing that's at risk, I think, are these reforms. Because remember, the people who are going to have to take responsibility for the budget and lead the achievement of this huge efficiency gain are family health physicians. Because in 18 months' time, less than that, they're going to have the money and they're going to have the responsibility to deliver those improvements within that reducing budget. So lots of issues for the health service, lots of potential opportunity for really good things, but as I say, some significant risks. Just really one slide about how NICE goes about its work. Lots of things I know that people think about NICE, but this is just a few things that maybe deal with some of the issues and questions you might have. The most important thing, actually, is it's probably the second bullet point, but the first is important too. Whenever we start off to do anything, we do our best to get all the evidence that's available. And it's not just the clinical studies, it's not just the economic assessments that are being made. What we do is we try to bring in all the perspectives of people who've got an interest in the decision that we're taking. People who are going to benefit in one way as patients, or the public generally, if it's public health, from the decisions that we make. Physicians who are going to be involved, the companies that produce the technologies that we might be making an assessment of, organisations, patient groups that act at a national level to speak as advocates for people who use healthcare in the UK. We genuinely try to involve everybody in it, and we're not frightened to take sometimes very strongly expressed views that are quite challenging very often, but because without doing that, we can't, whatever the decision is going to be, credibly present it as a rounded assessment of the evidence. We need to have all those perspectives in. When you look at a piece of advice from NICE, it's not written by me, it's not written by anybody I directly employ. It's written by people who sit on our independent advisory bodies. These are groups that are made up by and large of health professionals working in the NHS, but we have people with particular evaluative skills working with them. We have patient advocates. We have industry representatives where we're looking at the technologies that are developed by the healthcare industries. They do it without being paid. We give them a sandwich, we pay their rail fare, but that's about it. We give them a room that's got heating in, it's got lights, but there's no other remuneration. They do it, and it's a challenging thing to do, because if they do it properly, there's a lot of reading, there's a lot of thinking that needs to be done on top of their first or second jobs. And that's really important, because it's the independence of their thinking, their individual and collective judgment, that is the real strength of NICE. They're not told by anybody what to do. I can't tell a NICE advisory body what the outcome of a particular decision problem is. They certainly can't be told by a politician in the UK. There's no way that they can do that. I mean, I might get, though I never had, a phone call late at night from somebody in Whitehall. There's no way I could transmit the effect of that onto our advisory bodies. They do what they do because it's their interpretation of the evidence. And that's critically important, because nice advice is, what we produce, is advisory, not mandatory. We have to argue the case for the recommendations we make being picked up and used in the health system. There's nothing about what NICE does which requires a physician to do anything, or requires an NHS organisation to do anything. Save one thing, actually. When we make an advice on a new technology, NHS organisations are expected to put the resources in place to enable the decision or the technology to be used. But I can't instruct a physician to use the technology. And in circumstances where a physician thinks any recommendation to restrict the use of the technology is not in the interest of an individual patient, then they can go to the organisation they work for and make a case for funding outside of the guidance that NICE has produced. So it's independent, it's advisory. We take into account the evidence for effectiveness and cost effectiveness. So we're interested in value for money. Money's important. It's important here. People who make decisions in this healthcare system take money into account. Don't let anybody persuade you that's not the case. They do it in Switzerland, in Germany, in Japan, in Guyana, in South Africa, in Iceland. Everywhere anybody runs a health system, they're taking money into account. We just do it very explicitly. And that's part, I think, of what's interesting about NICE. We've shown how you can use good quality, systematic assessments of the economic impact of the decisions that we take, and take that into account in formulating recommendations in a way that's both valid and robust. The impact on the budget, therefore, is not direct. I don't control the budgets in the NHS. The impact of the guidance that NICE produces on a budget is a function of the extent to which our advice has been put into place locally. But we do, just to return to the point I made a moment ago about the quality and outcomes framework, we do more directly influence certain aspects of how money is spent in the health service by developing these indicators for the incentive payment mechanisms that I mentioned earlier on for primary care physicians and in secondary care. So final slide from me, a bit of a lead into Kalipso, talking about NICE's work internationally. What's interesting about what we do? Well, I think it's these things. We've demonstrated that it's possible to engage a whole system in the use of evidence to inform policy and practice. NICE is not perfect, and there is no immediate and slavish adherence to the advice that we produce in the NHS. But we have, over a decade or so, I think, had a significant impact on the nature of both the way the health service goes about the business of using money, and just to drop to the bottom bullet point there, on access to care, in terms of driving much more rapidly access, particularly to new technologies, and on outcomes, by encouraging the health service to use evidence to inform the decisions it's taken. We've pioneered methods and processes for sharing ownership of the assessment and interpretation of the evidence by putting in place solid, good quality arrangements for involving everybody who's affected in the decision, to bring them into a space where they can say what they want to say, and they come in and say it, and others listen and make their own judgment about it. But it's procedurally solid, and it allows people to feel that though in the end they may not get the answer they want, at least they've had the opportunity to express the view, and some reasonable confidence, I think, that that view has been taken into account. And we've shown how competing ambitions can be exposed and reconciled. That's particularly the case in the work we do in evaluating new health technologies. Companies, quite understandably, both proud and passionate about what it is they've produced. It's both for those reasons and for perfectly valid commercial reasons that they strongly advocate for their products to be adopted in health systems in the UK and around the world. That's absolutely fine. It's a perfectly reasonable ambition. We've got to make sure that the health services money is used to best effect. So the assessment we make of those new technologies and the judgment we make isn't always necessarily what the companies want. There's a different ambition, there's a different priority, the need to spread the resources that we have as effectively as possible, that's sometimes inconsistent with what companies are looking for. But the systems that we've got allow us to be open about it, transparent in the way we go about making judgments, and genuine in our involvement of companies and indeed other external partners and stakeholders in what we do. And that, I think, is one of the principal strengths of NICE and one of the principal reasons why there's real interest internationally in what we do. So again, thank you very much for the opportunity of talking today. Should we go straight to Kalipso?
Yeah. Do I have to do something about the slides? Or? Thanks. Right, thank you. Thanks, Amanda, and thank you for the invitation. It's fantastic to be here. So I'm going to talk a little bit about what we're doing internationally. So Andrew talked about institutions and about NICE as an example of an institution that is involved in making decisions about priority setting, and Amanda talked about the importance of processes for making these decisions. But why does it matter? Why is it becoming even more important that prioritization is thought through carefully by policymakers and those that are affected by the decisions the policymakers make? Well, first of all, I'd argue that it's because there's more money in it. So you've got countries like India, China, Turkey, Brazil investing more and more in healthcare. A big example is the Chinese rural health reforms, about $130 billion over 3 years. They've got another year and a half or a year to go, and they've got huge ambitions to expand coverage to all 800 million people living in rural China, reduce out-of-pocket costs, and give them access to an expanded package of services. So it does matter that these decisions are made properly, and there's a sort of a demand for accountability, certainly in China, sort of legitimacy and accountability of this extra money being spent. And what this shows you, and I got this from a PwC report, shows you how health spending is growing in different countries, and you see that China and India, for instance, is massive growth in health spending. In India, some of this is actually, most of it is out of pocket. Some of this here is also public money. But if you compare this to other countries, like, for instance, some of the European countries, it certainly trumps every other example. So there's more money going into the system. And there's more money, or at least a commitment to continue supporting international development by funders. So this is David Cameron. Interestingly, one of the first things, the new Prime Minister, one of the first things he did after the election was to reinforce the commitment of his government to supporting the Department for International Development. But what he also said, and this is a key priority for DFID, is that they'll make sure that that the aid will hit the spot. So they're talking about transparency and accountability to overseas aid, not to pull back even in difficult circumstances and sort of when the money is running out. But if we're asking the country to give more, it's our responsibility to make sure we get more for it. So it's the same sort of demand, request, or requirement as a policymaker as it is in national governments, to make sure the money that's being spent, taxpayers' money, is being spent efficiently. There's more marketing pressures, certainly in emerging economies, so more money and more products coming out through different channels, most of them commercial, but also not-for-profit channels. And China and India and sort of emerging markets are considered a major sort of target. This is Andrew Whitty from Glaxo. So China, Brazil, India are major target markets for growth for the health insurance industry and the pharmaceutical industry, devices industry. So the pressures are there. And then I think there's a very strong case for economic and social reasons for improving the accountability and the strength of the decision-making systems, especially in China, when it comes to the balance of the trade surplus. Major problem, major obstacle to getting Chinese people to spend is the fact that they save a lot. They save a lot because they're worried when it comes to health. They'll need to pay out of pocket, and they have to have savings to do that. So really, we're talking about an important part of the impacts on global economic policy. And similarly, there's social reasons as well. And this is from the Chinese English-speaking sort of channel. There's a lot of unrest, especially in rural areas, when people are asked to pay for healthcare and they can't afford it. Out-of-pocket costs are huge, people go bankrupt, and this is so this leads to social instability, and government is concerned about that and want to make sure that it's under control. So who decides now, and who is accountable? I like this quote from the former official in the Kenyan Health Ministry, who basically recently came to the United States, and the message he said that we're bringing to members of Congress and the US government is to say that we'd like now future investments in terms of health to come through institutions of government so that it's mainstream, it's integrated, and goes toward health system strengthening, and this sort of magical word, whatever health system strengthening means, but certainly to an extent at least locally led decision making. So what do we have what do policymakers in rich and in poor countries have available in their disposal to help them make decisions? Well, there's lots of guidelines, and there's NICE, but there's lots of other guidelines, very good guidelines, comprehensive evaluations of the evidence base, and people, I'm sure, log on, download them, and look at them. There's data repositories and synthesis. You've got here Tufts Cost Effectiveness Register, which is fantastic. The Cochrane collaboration, DCP choices, looking at the comparative clinical and cost effectiveness of things. You've got lots of networks. So we've got, that's the Guidelines International Network, Health Technology Assessment International, not sure what this is, but it's Health Technology Assessment something. Pharmacoeconomics networks, VIPNet, really good effort, WHO, to bring policymakers, involve people. And again, more networks and initials. And there's WHO offices in countries that are trying to help, but often they've got limited capacity, limited funds to specifically support capacity building. And then you've got lots of researchers, academics evaluating, you've got consultants, development consultants, you've got us thinking about things and talking about them at meetings in DC. So, but what I think, at least, in the sort of a number of countries that we've worked in, that's missing is flexibility by national ministers of health, social security, whoever is responsible for health, to allocate funds towards decision-making support for policy-making. And this is becoming even more evident as large funders are leaving some of these countries, so Brazil, China, India. So who's left to commit funds to build these institutions? It seems to me that the ministries of health that we talk to are finding it extremely difficult to have resources allocated and earmarked for supporting, building the technical capacity, the evidential capacity, and the institutional capacity to make decisions. And then there's very little sort of international aid, and this is from a WHO report that states precisely that there's very little funding for building capacity, staff, infrastructure, training, management, and it's expensive to run institutions. It takes a commitment. It's got to be a long-term commitment. And it's just not possible not to do it on the chip just by logging online using electronic tools. So maybe we need a path sort of a group that develops, instead of vaccines and drugs, actionable sort of decision support solutions. But it's got to be done locally. It's got to be implemented locally, driven locally, and then governments need to start paying for it. I think that's important. They're paying for drugs. They're paying. Amanda gave us lots of examples of sort of imbalances, one might argue, in the way governments spend lots of money on health. They need to start allocating some of this money towards institutions, local institutions, and towards training their own people to be able to make decisions. So Amanda said maybe we could sort of look a bit at economies of scale and what of the stuff that sort of NICE does and other organizations like NICE do are sort of totally context specific, and which ones may be sort of transferable. So there's lots of things to share. Certainly the methodology, analytical resources, using universities or already trained experts across different countries and regions. The processes, so legal challenges in Latin America are sort of shared, so that's something that countries can learn from each other. And then the clinical evidence. I mean, unfortunately, there's very little sort of perfectly generalizable RCT data. We all rely on FDA sort of driven randomized controlled trials when it comes to drugs, and we extrapolate. So whether we like it or not, a lot of this evidence is international and has to be transferable. Now, there's things like unit costs, volumes, the comparators, preferences, epidemiological data, and values, of course, and the structures that are very much context specific. Anyway, I'll skip that. So what comes first? I'd say that so far you've had we're having lots of these initiatives because people appreciate that there's a need to do something about decision making and priority setting. They've been producing good electronic and other tools, data collection systems, capacity building efforts have been sort of being put in place in different countries, and then you've got all the networks we talked about and data repositories for sharing, initiatives like DCP and so on. I think what we don't have a lot of is this, and I think that's problematic because if you go to policymakers with very good data, it's unlikely that they'll use it unless there's been a process upstream that helped them identify what sort of data they need and why they need it, or at least it's more likely that if they've been involved in the process of articulating the question, that they'll use the information to make decisions. So I would argue that this process up there, sort of building the political commitment and momentum and building the institutions, concentrates the mind and drives data collection, generation of evidence, capacity building, and then changing the system. So, for instance, in the UK at NICE has driven a lot of the capacity building in health economics and clinical evaluation, has influenced government to invest in methods research and prospective clinical trials in specific areas where we think, or our committees think there's evidence missing for them to make decisions. So it's what comes first, really, and that's something we can talk about later. The other thing that Amanda mentioned at the beginning is that there's different models in different countries, and I'm not going to go into this in great detail, but basically the scope varies from country to country, whether it's more or less linked to implementation, policy and financial incentives, and then, of course, the results, how much money each one of these agencies cost. Thailand is a great example. It's been around for 2.5-3 years, HITAP, not the country. So this is the sort of the NICE equivalent, if you like, of Thailand. It started off, it's an interesting model. It's sort of funded by institutional clients. So the government department or an agency in Thailand can go and ask them to do a specific piece of work. And they've commissioned work on HIV, drugs, the HPV vaccine. They've developed the essential drugs list. And what's happening now, which I think is really interesting, is that the government is asking them to put forward suggestions for making themselves indispensable to government. So the whole thing is streamlined. So they're saying, how can we do it so that we have to go to you when we make decisions? But there was a 2 or 3 year period where it was sort of model was being tested. And Australia, of course, is a very well-established example, NICE. It took a lot from the Australians over the years. But it's very much narrow. They only look at drugs, prescription drugs, in fact. And they don't really have an institution as such, so it's cheaper. They just have a committee supported by the Ministry of Health. So different models and different sort of attempts to solve the issue of setting priorities. Now, why be? It's not easy being open. Andrew talked about that. So there's lots of controversy, and a lot of the time the media sort of coverage might not be as encouraging as we would like it to be. And it is time-consuming to consult with people. It's expensive. You could sort of find yourself in a situation where everything is answerable through a model. So we've got numbers for everything. You've got us bureaucrats sort of resisting change because we like our jobs and the way we do things, so we know best. So there's all sorts of things. On the other hand, there are good things that I think I would argue outweigh the bad, even though I've got 3 bad and 2 good. But I've got another good coming in a minute. So engagement is good, and it's about legitimacy, and it's about communicating things to people, like getting people to buy into what we're saying. And it is about being consistent and explaining to people what the basis for your decisions are. And I think that's why large parts of stakeholders, at least the judiciary, certainly in the UK, industry, patients, have been broadly supportive of what we do. And that's my last sort of positive thing, is that it's easier. It's easier to do it like that. So my last slide talked about data and capacity. You need that, absolutely. You can't do cost effectiveness analysis or priority setting from DC for Kerala. You can't do it. You have to go there and you have to start looking. And it's, in fact, if you go there and start looking, you have to be invited by somebody to go and start looking. So it's the locals that need to look. And you need the capacity locally, and you need the local institutions. And to do that, I think, to get that, you need political backing locally. So in the UK, it's the government, Labour government, and now the coalition government that's supporting NICE and shaping it and funding it, because it's not cheap to build and run institutions. So I thought I'm really impressed by this guy. Apparently, he's a fellow in here, so that's fantastic. So that's my last slide. Legitimacy matters, and Andrew talks about process, transparency, scientific basis, being inclusive, asking people, being timely, being consistent, being independent. But the evidence is not enough. Values are very important. In fact, values shape evidence, or the way we interpret evidence. Processes are important, and maybe it's true that what Paul Romer said, that all it takes is better rules. Thank you very much.
to go along with the decisions that were being made. And there were also tragic cases where there were resources available and they weren't used. So, for example, oxygen being rationed when really there were stores of oxygen in the hospital that just weren't looked for and were found later. Evacuation being denied to certain patients when in fact the resources became available. So that kind of reminding us that sometimes when we think we have to ration, maybe we can find ways to avoid that. So those were some of the issues that came up in that I think kind of in this crucible kind of give us ideas of also that are relevant to non-emergency situations. And then I also looked at, in some of my reporting, at plans for emergency rationing. In particular, what would our hospitals do in this country if we were faced with a big run on the need for a particular hospital resource? And that's being thought about a lot, starting with SARS, then avian flu, then H1N1, this idea that maybe we don't, in this country, we certainly don't have enough ventilators and critical care resources to go around if there should be a real awful pandemic that affects respiratory systems in patients. And so there have been efforts, and again, it's very non-centralized and it's very non-transparent, but you should know that across the country on a state level, hospital level, even federal agencies, federal bodies like the VA hospitals have looked at and have drawn up very specific plans for who would get into the hospital, who would get ventilators, and who wouldn't in these situations. And in reporting on this and speaking with some of the decision makers involved, they all in these plans are very well written out. They all call for and stress the importance of public input because, as was just mentioned, values really underlie your decisions. So you can have all of the medical knowledge in the world, but you need to know what is it we're going to base our decisions on. Is it efficiency? Is it fairness, equity? So they all say we need lots of public input on these plans. Very, very few have gone out to get that public input. That's always the step that sort of, oh, we're going to work on that. That's the next step. And very little transparency around these protocols. And in fact, the few places, not surprisingly, Minnesota and Seattle, that have gone out and had some more inclusive public input on these plans about who would get access, have found that there are, in some cases, very significant differences between what healthcare providers think would be the way to go about this and what the wider, group of stakeholders, the public, and its various aspects of the public feel would be the right way. And one important aspect of this has to do with whether you not only set protocols for who would get access to your hospitals, but also who you, in some of these protocols envision actually withdrawing support from patients. And in fact, saying you get on a ventilator, you're going to be reevaluated after a certain amount of time. If you don't pass muster, we're going to take you off, therefore most likely leading to your death. And in some cases, the public felt that that was a step a little too far. So even if you could maybe say that that might overall save more patients because you're trying to maximize your clinical outcomes, that there is also the way that you define the greatest good, even if you're thinking in utilitarian terms, could also include things like trust in the health system, the trauma that it would pose to families, to caregivers of actually, against a family's wishes, taking that ventilator away from a patient, that should maybe be factored in, and perhaps we shouldn't envision this. And a second aspect that I think is very relevant to these discussions that comes up when you envision, setting time trials, for example, for ventilator trials, and then possibly removing them to give to patients you think could do better on them, are the limits on what we really know and what data can really tell us. Sometimes cost effectiveness, as you just mentioned, it sounds great, this math, it sounds so exact. We're going to do this, we're going to make everything more efficient. But what happened after the first wave of H1N1 was that some scientists went back and they did some studies and they said, what would have happened if we had applied some of these protocols to the patients in our ICU. So what if we had instituted the rationing protocols? If, thank heavens, H1N1 didn't get bad enough where we had to do it, but what if we had? Who would have gotten care, who wouldn't have? And what they found was that those protocols and the sort of scientific method by which you would add up a patient's SOFA scores, for those of you who know critical care scores, and decide whether or not to keep them on a ventilator, in fact, did not predict so well how a patient would actually do. And in fact, people who had H1N1 took a little longer on a ventilator before they started to get better than those protocols would have given them the time for. So you could envision, if you had instituted this, you may be cycling people off of ventilators again and again before anyone gets better, and in fact worsening your outcome, plus all of this social cost of the great trauma of doing that. So I think that it also reminds us that when we're looking at data, we need to be humble. And sometimes, perhaps, I would ask this question, is it perhaps better to say we don't know and to maybe not make a recommendation? Could we be doing more harm than good at some times? And most recently and finally, I helped to conceive and develop this radio series for PRI's The World. If you're interested, you can go to rationinghealth.org. All of the stories are in that. We looked at cases of healthcare allocation decision-making around the world. One of the pieces by my colleague Patrick Cox looked at NICE, and I looked at a couple of other examples, one of which I'll mention here. And I think the way that I approached this was I wanted to look at two things. One, on what basis are decisions about who gets life-saving care or life-extending care made? And number two, what are some responsible ways to avoid or cut down on some of the denials or the negative sides of rationing? And so in South Africa, I went to look at a situation where for decades health professionals have been rationing access to dialysis. And just for kidney disease, and for most of you probably know this, but if you have severe non-reversible kidney failure, your life expectancy without dialysis or a transplant is very short. And so this is a really, one of the most explicit examples of life and death rationing that you can imagine. And there's sort of three levels of where this allocation occurs. One is on a global level, where the vast majority of people who have access to dialysis are in the US, Western Europe, and Japan. In most of the rest of the world, the vast majority of people who need dialysis don't get it. So that's the first level of this. The second level is in South Africa as a whole and how they allocate their healthcare resources. And in fact, about 1 in 5 people has access to some form of health insurance there, by which, in fact, the government demands that all of these insurers cover dialysis. So these patients can get dialysis based on need alone. But for the rest, for the 4 out of 5, everybody else, they rely on the public health system, which the third level rations care by committee, hospital by hospital, and it is a heartbreaking process. And I sat in on some of these. Literally, they used to be called, when dialysis first emerged, and this was actually done in this country, life and death committees is the sort of name that they were given. And so I followed 2 patients, both in their 40s, both with severe non-reversible kidney failure who came up for being considered by this committee. They both had 3 kids. One was a man, one was a woman. Good jobs, never had a history of being arrested. Now, why do I mention this? Because actually these committees use social value criteria originally to make some of their decisions. And what they found was that, in fact, they looked back at their data, and so the way that they rationalized this was they said, look, this is a public resource. We are giving people access, it costs a lot of money to give them dialysis. So what is this person likely to give back to society? And that was one of the major things that they used to make these decisions. Now, not surprisingly, they looked back over time and found that there were wide variances based on race. So patients, historically speaking, and all the way up to recent years, if they were non-white had a much lower chance of being accepted for dialysis than patients who were white. And also, they faced, in recent years, the government decided to even further clamp down on how much money was going to be given toward dialysis programs and spend money on other things such as primary health care, HIV, etc. The doctors felt that they were sort of making these decisions for the health system. It was very, very painful. And so they said, we demand that there be a more inclusive process, that we sit down, we look explicitly at how we make these decisions, have government stakeholders come, and ethicists who said, no more, don't use these social worth criteria anymore. The problem, though, was that there are far more good medical candidates than there are slots. And so what did they fall back on? How could they make these decisions? Well, they look at things like, does the person have motivation? Do they seem motivated for care? Do they have good home circumstances, running water, electricity, which could help with home dialysis, which is one form of dialysis, peritoneal. And, of course, those proxies also have social implications and, again, tend to disadvantage certain people. So it's just by way of telling you that, and I guess it would raise a question, which is if we took the nice sort of approach and South Africa decided that this is just not a cost-effective, intervention, would it be better to not cover it at all? These two patients that I followed, one of them was approved, the man. The other was denied because it had recently been decided that patients who were obese would be turned away. They actually do better on dialysis, but ultimately kidney transplant doesn't work as well with them. And so the 42-year-old woman with 3 children was denied dialysis and went to a hospice and died. The 43-year-old man with 3 kids who didn't have that problem survived, and I actually got a photograph of him and his family just the other day from one of the social workers on the committee, and he just looks wonderful. So it just gives a sense of these are just impossible choices to make. I also looked at India, and I'll wrap up after this, where there was a run on a particular hospital in Pune, India, in the early stages, the panic of H1N1, where ventilators were in short supply. And this doctor, this pediatrician, found herself in the position of losing children and having to ration ventilators. And she actually thought outside the box and came up with a sort of a makeshift positive pressure breathing system, like a CPAP type system, that helped to bridge some of these kids to get better before they needed ventilators and reduce the need for ventilators and thus the need for rationing. So that idea that sometimes perhaps going to technologies that are even more, cost effective, less costly, looking backwards can be helpful. So I'd like to just sum up by raising a couple of questions for our colleagues who've been nice enough to join us. My colleague who did the story about NICE found he had one regret after, which is he felt he let you guys a little bit off the hook when you said that you were transparent. And what he meant was that he talked to 9 different economists, and some of whom had been involved in the committees that assessed technology, and not one of them could really describe how the numbers were come up with in terms of, yes, we know it has to, particular interventions have to meet a certain incremental cost effectiveness in order to be approved or considered approved. But he found that it sounded like clean math, but they don't show you the workings of how they got the numbers, the quality. Not one particular person who could say how they got that. The economists couldn't make sense of that. And so he asked, are you really any more transparent than any private insurance company? And so that's sort of a challenging question from him. And the second question was, I was surprised to find out that NICE assumes that most existing treatments are cost effective. Why is this? The choice of what to look at seems like a big part of your decision making. For example, you've gotten a lot of flack for the question of not approving all uses of certain Alzheimer's drugs. And are there sort of social value considerations of looking at Alzheimer's drugs versus looking at another group of drugs. So I'm sure you can inform me at, what guides those topic decisions besides just new therapies. And third, are there, and I think you've referred to this, the need to increase your efficiencies and avoid rationing, bringing down costs, and then finally, the values that underlie these choices are likely to be so different in different countries, and so how do you go about taking that into account when you do your consulting in various places? So thank you.
Okay, thanks very much. We have 15 minutes for questions. I'll invite the panelists to come back. I think it was great to have Sherry's examples of really how these systemic level policy issues can really translate into personal consequences or individual consequences for healthcare providers. One of the great things about NICE is that you can always blame NICE. I think that's one of your major functions, to take the slack. So why don't we take 3 questions from the audience, and then keep in mind the questions that Sherry posed, and you can respond. She's just going to bring a microphone.
Yes, hello. I just wanted to point out that in the city of Brandenburg, they just erected a new memorial to commemorate the victims of Hitler's T4 healthcare program, if you could call it that. Now, on March 29th, the European Journal of Cancer states that NICE, in its rulings on which treatments are to be accessible and under what conditions, has become more restrictive year by year and increasingly has based its rulings not on clinical effectiveness, but on cost effectiveness. Last year, to take one example, NICE rejected 4 drugs for advanced kidney or lung cancer, while acknowledging, as reported in the Independent of London, that the drugs do extend life by up to 6 months, but the money would be better spent on other patients. NICE has also progressively reduced accessibility of radiology treatments for cancer, causing those who have gone through chemotherapy to wait many months for radiation treatments and to forgo them entirely. And I just also want to point out that among women, 10 to 18% fewer Britons survive 5 years after breast cancer diagnosis than women in other major European countries. So I found it fascinating that NICE is actually seemingly trying to revive Hitler's T4 program, and I'm wondering if that's one of the things you guys model your cost effectiveness on. Thank you.
Okay, you always have to be suspicious when there's a Nazi reference, but welcome to the United States, and that's part of our debate here. Yeah, could you say where you're from, please?
Well, yes, I'm Rick Lopez with the LaRouche PAC. Thank you.
Okay, thank you very much. Okay, Sarah Bennett over here.
Thank you very much indeed. Perhaps I should start out by saying that I support fully the idea of transparent approaches to rationing healthcare. I wanted to ask Sir Andrew to talk a little bit more about the governance and the financing structures of NICE, and I'll explain why I'd be interested in hearing this. I'm interested in thinking about how you set up these kind of institutions in low and middle income countries. And I think that there's a fundamental tension in many countries between 3 things, which is firstly the financing or the sustainability of these kind of institutions. Secondly, their independence in decision-making, which you've emphasised today as being particularly important, and I think it is. And thirdly, their ability to influence decision-making at any level. And it seems to me that in many developing country contexts, where you have a situation that government is investing heavily, and then the institutions lack independence, and as a consequence begin to lose some credibility. Conversely, if you've got external funding coming in, they often lack influence as well as being perceived to be not independent but in another direction. So I think that there perhaps are some things we can do around the financing structures and the governance structures, but it would be interesting to hear how NICE is set up in that respect. Thank you.
Great. Okay, we'll take one more back here.
Hi, as a, I guess, younger audience here, I have one question that cannot be solved in my mind. Is that I remember like last year there were a whole bunch of quantitative easings that went to Wall Street and London that amounts to $1 trillion trillions and trillions of dollars. And I think in these discussions, I find it like the axioms is that we don't have budget to support certain patients. But as a younger generation, I find it kind of weird that we have a lot of money that we spend to bail out the banks and cannot save my grandma.
Okay.
What is that about?
Okay. Let's turn now to the panel. We have 6 questions, I think, on the table. You can be selective.
Okay. The first question I remember you putting about the economists who don't understand the numbers. I was a bit worried actually when you started asking the question, thinking maybe we need to just look at the CVs of the health economists that we're using. I think though the question that your colleague was asking them was how we arrive at the threshold range that we use, which is the kind of point of inflection in assessing cost
for a particular drug.
Well, then I'm very worried about CVs of our health economists, so I'm going to have to go back and check them. Because I'm very surprised. The method that we used is a fairly standard cost-utility analysis invented by health economists. And if health economists don't understand it, then it's a bit of a problem. So I don't know. Without knowing what the particular technology was, it's hard to answer the question.
Avastin, and so how exactly was it decided that it was worth, the increment was this much? And nobody could explain it.
Well,
we just need access to the internet. It's all in the public domain. So
yeah, I mean, there's an enormously long document that explains that. So it's a bit difficult, without him here and without hearing the answer to the question. But I'm going to check the CVs of the health economists. So just take the first of the questions from the audience that was put about cancer treatments becoming more restrictive. If you look back over the years, the proportion of drugs for treating cancer that we've looked at has actually increased as a percentage of the total in recent years. And that's because treating cancer, making sure patients have got access to effective and cost-effective treatments for cancer has become a priority for the government, so we're doing more of them. Our methods for assessing the value of these treatments haven't changed. So the variable has to be what it is that these new treatments are offering. Cancer treatments generally are introduced as last-line treatments initially, and what the companies do is to try and move them up towards first-line treatment. The other thing, of course, they do is to try and extend the range of tumour types that a particular drug is introduced for. So it might be introduced first for breast cancer, for example, and then companies will do studies to see its impact in lung cancer and other solid tumour sites. So I don't think our methods have changed. So if the proportion of more restrictive recommendations, and bear in mind when we talk about this, we're talking about a very small number of treatments, because again, in the majority of cancer treatments that are introduced, NICE's independent advisory committees find value and make positive recommendations. But where those restrictive recommendations are made, it's on the basis of the offer of the treatment itself. It's the same assessment being made of the incremental benefit of the new treatment compared to current standard therapies that we're using. I don't know what the reference is to reduced access to radiotherapy. That doesn't ring any bells for me in terms of the advice that we've given. And survival rates, by and large, and this was confirmed in a recent report by Mike Richards, who's the National Director for Cancer in the UK, are not significantly influenced by long-term survival rates, not significantly influenced by access to drugs. It's about the critical issue there is the point at which diagnosis is made. And there is a problem in the UK. The UK is not as good as other European countries in early identification, early diagnosis of cancer. That's the key area that the UK needs to improve on. If we can get that sorted out, then our survival rates are going to be equivalent, I think, to other European countries. On the question of financing of NICE, NICE is funded by the UK government. The money comes through the Department of Health. That's where the cash comes from. It's on a programme-by-programme basis, so we've built up our funding over the years. If you remember that chart, that short history of NICE, you can see the programmes building up over the years. We've been extraordinarily fortunate in having political support right across the spectrum in the UK. So we have the confidence of the range of political parties. That's why NICE has survived the recent transition following the general election in the UK last year. The governance arrangements, well, NICE is what's called a special health authority, so it's governed by a board of non-executive and executive directors. There's a chairman. It's a public body, so we have to account for our money in a very public way, and we have to account for the way in which we use the money to the sponsoring department. That's the Department of Health. But otherwise, NICE is an independent organisation. The government doesn't tell us how to go about doing our work. It doesn't instruct us in our methods and processes. And as I said in my presentation, it doesn't have the ability to tell our advisory committees what it is that they do. Kalipso, I don't know whether you want to pick up on the issue of how, the governance model for institutions that have been built in countries outside the UK essentially has to be done on the basis of affordability, the resources that are available, and the sort of culture of the countries concerned. The model that NICE is governed on isn't necessarily the model that works, or for that matter needs to be put in place elsewhere in the world.
And I think that's a good point about where the money is coming from, and then what the sort of the balance between being able to make decisions that have some traction, and having the money to then fund these decisions and how it would work. But I think, for instance, what you guys are talking about here, the sort of the cash on delivery model, would be an interesting way to think about this, to see how the cash flows, and then look at through what sort of institutions locally you could, if you want to make people accountable locally and globally, or at least in the UK, then there's different levels at which you can think about criteria and measures for whether they're delivering or not. So I think it's about trying to build a model that fits the country, and trying to stop wanting to bypass local decision makers and just target things that people who hold the money, the donors, think is a key priority. I think institutions have to be local. You can't do it from outside.
Just on the final question, is a very good point. If we can afford to put the billions of pounds and dollars and euros, if you added all that right across the world, that's been put into salvaging the banking system, why can't we make that investment in health? Then a lot of these problems go away. Certainly the magnitude of the cash that's being put in place would make it much easier to make more generous assessments of the benefits of all sorts of treatments. So what's the answer? Well, I don't know, you probably have to ask the politicians that, but they'd say, well, if we don't make this investment, then the prospects of having any resources in the medium to long term to fund health are put significantly at risk. So we're doing this, though we know it's spending money in circumstances that many people find hard to deal with, because in the long term, if we don't, then our ability to generate wealth to fund the health systems that we want in the future simply isn't going to be there. Now, how credible that argument is a matter, I think, for personal judgment, but that's, I think, the line that governments would take generally to defend the actions that they've taken to put money in. And, of course, the fact is that it's not as if it was money just sitting on the shelf doing nothing. The US will experience it, the UK is experiencing it now. I can't remember exactly how much money was put in the UK, certainly in excess of £50 billion. It's a lot of money for the UK, and we're now having to pay it back. NICE's budget, the budgets generally for the public sector, for central government functions in the UK, reducing by almost 30% over the next 3 years. NICE's budget will probably be reduced by a similar amount, though we can't be absolutely certain at this stage. So we're going to have to, in effect, contribute to paying it back. So it's difficult, and I can see why you've asked the question, why you feel the way you do. I share that. I suspect do most taxpayers. But I think I probably accept the government's logic that if we hadn't put the money in to salvage the system in the long term, things would have been much more difficult than they probably otherwise would be.
Okay, Sherry, would you like to say anything else? Okay, let's take another. Please say who you are, identify yourself first, and then ask your question.
My name is Sam Wainwright. I work at the New America Foundation here in DC. And we've been doing a lot of work looking at, Sorry. We've been doing work. I'm trying to keep this from feedbacking, but we've been doing work looking into. Do you mind if I just stand up and
Yeah,
talk?
that's fine.
Looking into whether or not we can actually change perceptions around treatments like palliative care in the case of late-stage terminal cancer. And I was wondering if NICE's work with transparency and also with decision aids, both for clinicians and for patients, what your impression has been on the effectiveness of changing public attitude towards the treatments that might both be evidence-based, more effective, and cost-based, more effective?
Yeah, the broad point there is the challenge that you've got to try and persuade people that the thing that they just read about in the newspaper, the latest exciting dramatic innovation, almost certainly somewhat misdescribed in the newspaper's headlines in terms of what it's going to offer, needs to be set against everything that we've currently got and the different things that might be available. You asked the question about Alzheimer's treatments. It's an interesting example because the drugs for treating Alzheimer's, which gradually, our advice has evolved to now broadly supporting the use of all of these treatments in the mild and the moderate stage of the disease, do offer something to some patients. They're not terribly effective, but they do bring some benefit. So to the extent that that's there, then it's appropriate and right that the NHS should make the drugs available. But the biggest contribution right now to supporting people living with all forms of dementia and the many people who care for them is a much different kind of support. It's the sort of support that helps carers get some relief in some circumstances from the 24-hour-a-day relentless pressure of looking after somebody they love who's got dementia. It's providing physiotherapy, home care aids, all sorts of other things, all of which actually NICE has recommended in a more broadly based clinical guideline on dementia. And when we were making our recommendations about Alzheimer's treatments, and there were some restrictions on the use of them, it was very difficult to get that point across. So it's not that drugs are unimportant, but they're not the most important thing that we need to do for people with that disease. So that's not the palliative care example that you've got. And I think in the UK setting, broadly speaking, people understand the value of palliative care. The problem with palliative care, rather more specifically, the problem with end-of-life treatments is it deals with one of the most sensitive aspects of healthcare, the ability of a health system to rescue life. And whereas, generally speaking, if we get run over in the road and we get brought into the accident room, you don't find lots of detailed economic studies about the benefits of whether or not you should be wheeled into the intensive care facility or not. If there's the ability to rescue life, you get wheeled into the intensive care facility, and all the resources that are available at that time, at that moment in the emergency room, are brought to bear to drag you back from the jaws of death. And people think that's fine. The judgments about what to do at end of life when we're facing the inevitability of the end of life, because we have a disease, whether it's cancer or something else, which has brought us to the end of our lives. And what we're talking about is not the prospect of being dragged back from the jaws of death after a road traffic accident with a prospect of 30, 40, 50 years of life. But what we do in circumstances where the prospects that treatment might, in some circumstances, bring us perhaps weeks of extra life. Very, very difficult judgments to make. An extra week of life is a priceless thing. And yet, the health system, because it's funded publicly in the United Kingdom, in other circumstances funded in some other way, has got to make a judgment about whether or not that is the first priority, that in any circumstances, whether it's a day, a week, a month, or 40 years of life, the first duty of the health system, the first call on its resources, is to provide that, is to do everything possible to buy the potential for that extra life. Now that's a decision, a perfectly reasonable decision a health system can make if it wants to make it. But it has to make it explicitly, and it has to make it on the basis that it understands the trade-off in the other things that won't happen if that's the choice that it makes. And NICE is simply part of a process which in its way is exploring these issues, it's bringing them to the attention of the public, it's trying to provide some open, as transparent as possible, with people competent to do the numbers around it, method of just cracking all of that open and taking a look at it, rather than pretending it's not a problem. and giving the decision to people who struggle with it as best they can, but who don't have to expose their thinking and the puzzling out of the problem that they have to do. So that's all we're doing, really. It's not perfect, but at least it's a way of getting to a bit of a digression from the point that you make. But I think it's a good point that actually, when we're faced with different opportunities for dealing with different circumstances, whether it's dementia or whether it's people facing the end of their lives, we have to look right across the board at the opportunities, and through its different programs, that's what NICE tries to do.
Okay, thanks. We're going to end with a comment then from Sherry.
Oh, well,
So be
okay.
significant, profound.
Well, I guess this raises the question of, and the whole question of transparency. What is, or how do you arrive at that Q in the quality adjusted life year? How do you decide what quality means? And I guess I wanted to raise this question. Is explicit inclusive rationing sustainable? It's something that we, as I said, shy away from in this country, even opening these discussions to the public. Do you think that this is a sustainable method, or will it's taken some pot shots in the UK? There's now a fund set up for cancer. Often the answer is adding more money, but what do you think?
Well, I think two things. One is whatever we do, whatever our endeavour is, public or private, making judgments about value for money, because it's just will always have to be done. It doesn't matter in our personal lives, in our professional lives. There can't be any of us in this room who don't, in some way, explicitly or implicitly, consciously or unconsciously, make judgments about value for money. So that's going to have to be there. So I think that will just be a feature of health systems and any other kind of human endeavour. And the second thing is that it's true we can, as the government has done recently in Britain, decide that some aspect of healthcare delivery is so important that they want to add in additional resources for the long term or for a fixed period of time, whether it's cancer or something else. These are choices that still need to be made. Putting in extra money for cancer or for dementia or for people with learning disabilities or whatever it is, doesn't mean that you've solved the problem of funding the health system. We, the people who benefit from health systems, will continue to push health systems to do more than at any one time they're capable of doing. So some judgments have to be made about the limitations of what the offer is, whether it's privately or publicly funded. So I think health systems need to confront that with transparent, systematic, consistent approaches to making judgments about value for money and making choices about the priorities, which may change from time to time, that the health system's got.
Okay, well, with that, we'll conclude. Stay tuned for more work on this topic, and we'll look forward for hearing from you in the future. So thank you very much for joining us today.